All right, thank you. Coming up is Dr. Johnson, Dr. Tyler Johnson. I happen to know this gentleman since 2009, being his senior resident at Stanford. I think this guy you've read all of Harrison's, haven't you? He was also chief resident and then followed up in oncology, and he's one of the up-and-coming young GI experts. I am happy that you accepted to come and talk to us about non-colorectal cancer updates.
You know, it's always kind of funny when you go to GI ASCO or to the regular ASCO meeting, you have one meeting hall that's for colorectal cancer and then another meeting hall that's for all of the other like 8 GI tumors. I always thought that that was because colon cancer was just so much more common. It wasn't until today that I learned it was actually because of German philosophy. So I'd really like to thank Dr. Lenz for teaching me that. It's always a little bit intimidating when you're asked to give the non-colorectal GI cancer talk because you do have to sort through so many trials from so many different places to figure out what to talk about. And what I've tried to do today is to distill down from the last year or so of data, what are some practical take-home points that people who are practicing right now can use. And so I hope that that is what I have done. One thing I want to let you know, so my slides come in sort of 2 flavors. A number of them I have borrowed from ASCO and GI ASCO presentations, and so I thank the people who made those slides originally for allowing me to use those. The ones that I have made are purposefully made to be very simple. I do that because I want to allow you to focus on what I think are the most important points rather than being distracted by clutter on the slides, so just know that that is purposeful. So here are the things that I hope you will learn in the next 20 minutes. These are your take-home points. I'm giving them to you right up front. So FLOT is now considered the go-to for all adenocarcinomas of the stomach and esophagus in the perioperative setting. We'll talk about the data that leads to that conclusion. Zolbetuximab is now available, and Claudin 18.2 should be part of standard analysis for all gastric and GE junction adenocarcinomas. We should take great care in assessing elderly and frail patients with metastatic pancreatic ductal adenocarcinoma and in choosing their chemo regimens. And finally, while immunotherapy is not yet standard in the perioperative treatment for patients with gastric and GE junction adenocarcinoma receiving FLOT, it may be soon, and we will talk a little bit about why that would be the case. In order to review these things, we will review the following trials: ESOPEC for FLOT versus CROSS, SPOTLIGHT for zolbetuximab, GIANT for the treatment of metastatic pancreatic ductal adenocarcinomas who are elderly and frail, and then chiefly Matterhorn we'll talk about briefly right at the end in the context also of Keynote 585. So here is take-home point number 1. FLOT is now considered standard perioperative therapy for all fit patients with resectable locally advanced adenocarcinoma of the gastric or gastric esophageal junction and esophagus, and we will talk about that. So this is the ESOPEC trial scheme. This is a relatively straightforward trial design. Remember that we have known for a long time, for many years before this trial, for patients with esophagus cancer, neoadjuvant chemoradiation a la the CROSS trial was considered the standard of care, but we know from that trial that the radiation, not surprisingly, seemed to be much more effective in patients with squamous cell carcinoma of the esophagus rather than adenocarcinoma of the esophagus. We also knew that FLOT had become the new standard perioperative chemotherapy regimen. Remember that until a few years ago, we used to use harsher chemotherapy regimens that also included anthracyclines, but we almost never use those now because the FLOT4 trial demonstrated that FLOT was more effective. And so the question was, if you compare FLOT directly to CROSS as the sort of perioperative versus neoadjuvant therapy, which would be more effective? It's important to note that this only included patients with adenocarcinoma, so this does not apply to patients with squamous cell carcinoma of the esophagus. Those are increasingly considered as different entities, largely because of this trial. These are the characteristics of the patients in the trial. They are relatively well balanced, as you would expect in patients with in a randomized design. And this is the take-home slide. So the median overall survival in the intention to treat population is statistically significant significantly better for patients who received FLOT as opposed to patients who neoadjuvantly received CROSS. And so largely based on this is our, our gold standard in terms of what we look at in terms of long-term survival, and so this establishes this therapy as the standard of care in this setting. This is looking at subgroup analyses, and you can see that although there are a couple, for example, node-negative tumors where it looks to be relatively similar on both sides, for the most part, all of these subgroups favor using FLOT. This slide is meant to demonstrate that if you look at the pathologic complete response rate at the time of surgery, there is a statistically significantly and arguably clinically meaningfully improvement in the median or in the complete pathologic response rate using FLOT as opposed to CROSS as well. So a couple of notes to think about this in context. CROSS is often pretty well tolerated. One thing that is nice about it is that the chemotherapy is given in smaller doses weekly, which allows you a lot of chances to modify the therapy that you give based on toxicity. FLOT is pretty tough. Many patients who receive FLOT end up getting at least dose modifications, and a number of them can't even finish all of the planned cycles of chemotherapy because of side effects. It's also important to note that especially in elderly patients, the neuropathy that comes from getting 4 months of oxaliplatin, as you get with FLOT, is not insignificant. It's better with 4 months than with 6 months, as we used to do in the adjuvant setting and sometimes still do, for example, with colon cancer, but it is still worth noting that the neuropathy is not insignificant. It's also important to note that we had previously been giving, just for the last couple of years, adjuvant nivolumab. It's not clear what to do about immunotherapy for patients who have esophageal adenocarcinoma and receive perioperative FLOT, although we will talk about that a little bit more further in the presentation. But I think there is pretty widespread agreement now that for these patients, perioperative FLOT now stands as the standard of care. Take-home point number 2, Claudin 18.2 should be a standard part of initial pathology analysis, and zolbetuximab should be seriously considered as part of initial therapy for patients who have metastatic gastric or GE junction adenocarcinoma. This is, we're going to talk here about the Spotlight trial. Again, I thank the authors and presenters for the use of these slides, which were presented in GI ASCO. This is just a reminder that Claudin 18.2 is a tight junction protein and that zolbetuximab is a monoclonal antibody directed against it. This again is a relatively straightforward double-blinded RCT design where you have on the one hand chemotherapy plus placebo versus chemotherapy plus zolbetuximab. This is again showing that the two arms of the trial are well balanced, as we would expect. And this is the primary endpoint, which is progression-free survival. Note that it was assessed by independent review committee. And what you can see is that if you look at the 12-month time period or the 24-month time period, there is both a clinically or a statistically significant and clinically meaningful benefit of adding zolbetuximab. At 12 months, you have a progression-free survival of nearly 50% versus 35%, and even at 24 months, you have 24% versus 15%. With the median median progression-free survival, being almost 11 months versus approaching 9. Again, if you look at subgroup analyses, in most cases there are a couple that are close to equilibrium, but in most cases you have an improvement with the zolbetuximab arm, and as a key secondary endpoint you also have improved median overall survival. I think it's also worth noting that as we see, similar to what we see in some of the immunotherapy trials, there does appear to be a clinically meaningful tail towards the end of this curve where you have that about 20% response rate that seems to be continuing, although there may be some fall-off. It's hard to tell because we don't have mature data and the numbers are getting fairly small towards the end. It is very important to note that this can be a pretty toxic drug, especially in terms of nausea. One thing that is interesting about this is that the nausea tends to happen especially in the first few doses and then tends to wane significantly after that. But in terms of lifestyle and patients who are getting started on the drug, it's important to warn them about this and to make sure that they have the appropriate adjunct therapies and hopefully access to an infusion treatment area in case their nausea becomes particularly severe, because as you can see in this slide, nausea and vomiting were significant components of the adverse events here, much more so on the zolbetuximab arm than on the FOLFOX arm, even though FOLFOX, of course, on its own can also be quite emetogenic. So this is a little bit more complicated to consider in context. Of course, these patients have a generally poor prognosis, and so the advent of any new bioavailable drug here is something to be very happy about. It is also important to note that a significant percentage of people do have an increased expression of Claudin 18.2. However, patients could only be enrolled in the trial, for example, if they were HER2 negative, and we still don't really know exactly how this is going to play out with respect to immunotherapy. As those of you who treat these patients will know, the decision of when to use immunotherapy in the first-line setting with chemotherapy for patients with metastatic gastric cancer is a little bit complicated, depending on their microsatellite instability status and their PD-L1 CPS. Having said that, I think that certainly for patients who have a low PD-L1 CPS and who are HER2 negative and microsatellite stable, I think the addition of zolbetuximab is likely beneficial. For patients who are HER2 positive or have a high PD-L1 CPS, I think we still need a little bit more time and experience and further data to know exactly how to proceed. It's also worth noting, as those of you who follow this story are probably aware, this data has actually been available for some time, but the FDA had not approved the drug until just a couple of months ago due to manufacturing problems with the drug. That was held up, and so it's only in the last couple of months actually become commercially available. Take-home point number 3, take great care in treating elderly and frail patients with newly diagnosed metastatic pancreatic ductal adenocarcinoma. This data is perhaps not paradigm shifting per se, but I think it is an important reminder of something that we maybe don't pay enough attention to clinically. So these are results from the GIANT trial, which is a trial trying to identify what is the optimum chemotherapy regimen to use in patients with newly diagnosed metastatic pancreatic ductal adenocarcinoma who are elderly, relatively elderly, or frail. This is just a reminder. If you look at this chart right up at the top, it's important to remember that many, if not most patients, depending on where you draw your cutoff with newly diagnosed metastatic pancreatic ductal adenocarcinoma, are chronologically elderly, and even those who are not chronologically elderly may also be physiologically frail. And so this slide is basically emphasizing that in this trial they used some geriatric assessment tools to try to identify patients. So on the one hand, if you were young and fit, you did not qualify for this trial. But on the other hand, if you were quite elderly or very frail, you also did not qualify. So they are not trying to enroll patients here who are debilitated from their frailty, but rather those who are starting to show the signs of their age or who are starting to have some significant medical comorbidities. This, again, is just emphasizing that point. The baseline characteristics were relatively well balanced, including in terms of their age. You'll want to notice there that a significant proportion of the patients on this trial were greater than 75 years old. I think two things can be taken home from these results. Again, this is looking at the primary endpoint, which is overall survival and the intention to treat population. The first one is that, as you can see, the curves basically overlap with each other. There is no statistically significantly or clinically meaningfully difference in between the two arms. But the other thing that I think is pretty sobering here is that if you look at how patients did just in general, these are pretty sobering results, right? All of these patients had a very hard time. That also holds up if you look at the progression-free survival. You can see that your 50% mark there, you're barely, not even quite to 3 months. Now, you do get a little bit more clarity here if you subdivide them. I think the most helpful thing here, it's interesting to note that if you divide them by age, you actually don't see a lot of difference here. But if you divide them by performance status, you do, right? So the patients who had a performance status, an ECOG performance status of 0 or 1, did statistically and clinically meaningfully better than those who had a performance status of 2. And so I think that, and if you look at the specific adverse event profile, these are most of the things that we expect to see with the chemotherapy regimens that we're talking about using here. There's nothing greatly surprising, except that I think it's just important to note here that these patients who were a little bit more elderly or a little bit more frail had quite high numbers in all of these things. And so I think that when we try to put all of this in context, I think there are a number of things that are important to take home here. One is that, as most of us know, metastatic pancreatic ductal adenocarcinoma just at base is a tough nut to crack. It's just a hard disease to treat effectively. I think there have been multiple CTs that have shown the benefit of multi-agent chemotherapy regimens in treating these patients. Having said that, though, it's important to remember that, as some people like to say, those trials often include, quote unquote, the marathon runners of pancreatic cancer patients, the very most fit ones. And so how that marathon runner data applies in your patient who is 80 years old and has some significant comorbidities and a performance status of 1 or 2, I think is still up for debate. I think that the one thing that I will say just from my personal practice, though of course this is not derived directly from the data that I've presented here, is that I would consider in patients who are elderly and frail, I would consider gemcitabine alone. I say that for 2 reasons. One is because it is often well tolerated, although even then, even that medication can cause significant cytopenias. You often have to go to the Q14-day dosing rather than the days 1, 8, and 15-day dosing. But the other thing is that I have noted in my own practice that there is a significant subpopulation of even elderly patients who on single-agent gemcitabine can do very well for a very long time. I've seen patients even in their 80s do well, sometimes for years, on single-agent gemcitabine, which is just to say that I don't want us either to overlearn the lessons from this trial. In other words, I don't want us to think, oh, well, if they're going to get that sick with chemotherapy, I just won't give anything. Rather, I think the last point here is really the one that matters the most, which is that we should be thinking specifically about that it's not just about chronologic age. I think we need better and more accessible tools for general oncologists to assess physiologic frailty so that we can tailor our therapeutic regimens according to those kinds of variables. And also, if you have access to it, it can be very helpful to partner with a geriatric oncologist who actually has subspecialty niche expertise in this area. Take-home point number 4 is that we don't yet know how to incorporate immunotherapy into the perioperative therapy of patients undergoing resection of gastric adenocarcinoma, but we're working on it. I want to focus here on the Matterhorn study, which, again, we do not have final results from this trial, but just so that you are aware, because this becomes very significant given the data that I presented at the beginning, this is a randomized controlled trial where you have FLOT plus durvalumab in one arm versus FLOT plus placebo in the other arm. You can see that there are patients from all over in this trial. Just for the sake of time, I will show this is data that has been presented, which is that if you look at the pathologic complete response in these patients, you can see that there is a statistically significantly, and you could imagine, though we don't know yet, clinically meaningful improvement in the pathologic complete response rate. And then if you look at the combined complete and near complete pathologic response rate, that is statistically significantly higher as well. And so I think that in context, as we talked about at the beginning, perioperative therapy with FLOT is the new standard of care for patients with resectable gastric adenocarcinoma. We don't yet know how to incorporate immunotherapy, but we are awaiting results and will be eager to know what this shows. So one more time, just to review very briefly the take-home points from this presentation. Perioperative FLOT is the new standard of care for the treatment of resectable adenocarcinoma anywhere in the esophagus, GE junction, or stomach. Zolbetuximab is a new option, which is now widely commercially available and FDA approved for adding to initial chemotherapy for the treatment of newly diagnosed Claudin 18.2 overexpressing metastatic gastric or GE junction cancer, especially if IO and anti-HER2 therapies are not preferred. Care should be taken in the treatment of elderly or frail patients with newly diagnosed metastatic pancreatic ductal adenocarcinoma, and we await the results of the Matterhorn trial. Thank you.